Good morning, everyone. I'm Sathish Kumar Natarajan, an assistant professor in the Department of Nutrition and Health Sciences. Before we go into the mechanism of insulin signaling and glucose regulation in diabetes and the complications, first I would like to thank the organizers of Botany for You, an online platform for students for life sciences, and they have started the new initiative of life science discussion forum. And this is an awesome opportunity for young students in India and rest of the world. The mechanism of insulin signaling and is vast, and I'm going to be very brief about this. And I wanted to introduce the knowledge of diabetes. And we know that there are various symptoms of diabetes, and something that I wanted to take you through in the slide, that if someone gets diabetes, they are tired. That would result in frequent urination, and some of us lost weight who get diabetes. And there's also a problem of wound healing, sexual problem, and for men and women there are vaginal or urinary tract infection. And you also are highly angry or always angry, and that high levels of blood sugar level also results in blurry and vision problem, and the thumb and the hand or legs would get tingling or numb sensation. In addition, we are always thirsty because we are frequently urinating and these are the symptoms that we should know about diabetes. And with one hormone or peptide hormone that we have in our system is insulin, that regulates against glucose, high levels of glucose in the circulation. We have any other organs, peptide hormones that are present in our body that helps in increasing the levels of glucose during the fasting state. For example, glucagon, epinephrine, and norepinephrine get secreted when someone is hungry, and that response results in increasing glucose level. But we only have one peptide hormone, insulin, that is secreted from the islets of pancreatic beta cells, and these cells produce insulin in a response to an increase in glucose after a fed state. And this is the normal physiology where someone would consume high level of carbohydrate diet that results in increased levels of glucose in the circulation, and pancreatic function is to sense these high levels of glucose in the circulation. Pancreas is to sense the high levels of glucose in the circulation and secretes insulin. Insulin comes to a cell, majority of the cell, for example, in adipose tissue and in muscle and in the liver, it tells our body to utilize this excess glucose that is present in the blood circulation. The way insulin reacts with an insulin receptor, and that results in signaling events to utilize this glucose, and we have glucose transporter inside the cell, and that glucose transporter goes to the plasma membrane, which would normally present inside the cell. And insulin would also result in increases the amino acid uptake, and glucose absorption that happens from the insulin would be taken up by the muscle and adipose tissue to form glycogen. And glycogen is the polysaccharide that is present in our liver, and you can only store so much in the liver, and muscle enormous amount of glycogen is stored. And when there is a need for glucose during a fasting stage or during starvation, you would release that glycogen, or glycogen gets broken down to form glucose. And the glucose undergoes a process called glycolysis. It's called an oxidation of glucose to fuel or ATP. And excess levels of glucose can also be converted to triglycerides. And if there is a need, and if the signal is not present, and that would be stopping the, if there is a glucose, high levels of glucose, the free fatty acid release from triglycerides will not happen. That's one of the signaling pathway of insulin. And if there is glucose, high levels of glucose, we would probably utilizing more of the glucose into the energy utilizing process, and excess of glucose is stored as a fatty liver disease. And that's, we have high levels of glucose is highly associated with obesity or metabolic syndrome, and turn back towards highly associated with insulin resistance, and people who develop insulin resistance, that's what we're going to solve. This is a brief overview of insulin signaling, and life science students would have studied about this, but I'm just taking you through what happens in the process of insulin action into the cell. There are various levels of metabolic effect that happens. One, we increase glucose uptake in the muscle, glucose uptake in the liver happens, and the target enzyme in glucose uptake in the muscle is glucose transporter. Some of the well-studied glucose transporters are called GLUT4 and GLUT1 to 4 are different types of GLUT, which are the transporter present in the liver, intestine, that so on, which has been known to have various function in. And insulin would act on many levels of kinases and activation that we would in a minute we'll go. So in the liver and muscle, what happens, increasing glucose levels would increase the glycogen synthesis, and insulin also stop glycogen breakdown by phosphorylating and phosphorylating the glycogen synthase and glycogen phosphorus. To increase glycogen synthase, you would have signal of target enzyme glycogen synthase get increased, and glycogen phosphorylase, which is a synthesizing enzyme, it gets decreased when there is a need for glycogen breakdown, and it is an opposite uh, function, but it also blocks glycogen breakdown that is stored in the liver or in the muscle, so that more glucose is not released into the circulation to maintain that process. And insulin would also act on increasing glycolysis and acetyl-CoA production for TCA cycle by increasing the enzyme, or a key enzyme in glycolysis is phosphofructokinase. And acetyl-CoA production is via increasing the pyruvate dehydrogenase complex. And excess levels of glucose would also result in increased free fatty acid synthesis or fatty acid synthesis, and that is by activating the acetyl-CoA carboxylase enzyme. And glucagon, in the opposite of insulin, would do the opposite action by activating the protein kinase A and phosphorylate acetyl-CoA and decreases the activity of acetyl-CoA carboxylase. But in the presence of glucose, acetyl-CoA carboxylase gets increased because we need to increase the utilization of glucose from the circulation when there is a fed state. And these are the quick overview of glucose. What is diabetes? If there is any dysregulation in the process or glucose homeostasis, that is diabetes. And we know there are two types of diabetes, type 1 and type 2. And type 1 is completely insulin deficiency. If there is any, and usually occurs in early or young adolescents, and then type 2 is basically results in insulin resistant and reduced reduced to production of insulin, and there is insulin deficiency. However, in the early time point of type 2 diabetes, there will be hyperinsulinemia, or there will be a compensation of reaction that goes on in the system, and when that compensation is no longer effective, that results in type 2 diabetes. We have to remember that type 2 diabetes and type 1 diabetes is being classified as insulin dependent, non-insulin dependent diabetes. That's not a good definition. And also adult onset diabetes and juvenile diabetes, it's also not a wrong classification, because type 2 diabetes has been occurring in children and adults of age at 13 to 15 because of high incidence of obesity and metabolic syndrome. Because of this, we no longer call type 2 diabetes as adult onset diabetes and type 1 as juvenile diabetes, because we have seen patients, or we have been seen publications to show that at the age of 8 with severe obesity, and children do get type 2 diabetes, which is not in the developed nation and in the developing nation. To dig into details of the type 1 diabetes, there are various factors that are involved in the generation or in the disease pathogenesis. Some of them are listed here as immunological reaction or an autoantibodies against pancreatic beta cells or islet cells, and some of the genetic factors and infection of enteroviruses and environmental factor has been together or alone associated with type 1 diabetes, and that results in high blood glucose levels, ketogenesis, and long-term and short-term difficulties. And these type 1 diabetes are known to form atherosclerosis or a block in their arteries, and they also undergo blindness, renal injury because of high levels of glucose circulation, and then infection. And insulin therapy is a very easy treatment, and there are insulin pump that you can insert into the person's circulation, and that would basically detect the levels of insulin or blood circulation, glucose levels in the blood circulation, and that prevent any hypoglycemic events. So to give you a overview of etiology of type 1 diabetes, there has been a combination of predisposition or genetic predisposition, environmental factors, and that results in insulitis. That means pre-insulitis, there is some inflammatory reaction happens, and peri-insulitis, that the insulin producing cells gets targeted by these antibodies, and intra-insular insulitis, and that results in complete destruction of pancreatic islet cells. If you have destroyed all the pancreatic islet cells in the pancreas, there is no insulin production. There is no new insulin production. That results in type 1 diabetes. And most of the time, these autoantibodies, meaning that antibodies that is generated against our own protein, causes this dysfunction and results in type 1 diabetes. And I mentioned juvenile onset and insulin dependent are the previous classification, but we now call them type 1 diabetes. It's usually happened due to autoimmune and as a consequence of destruction. That means destruction of insulin producing beta cells in the islets of the pancreas. The beta cell destruction results in loss of blood control because there is no insulin, and that results in insulin deficiency, or there is no insulin producing cells, and it causes hyperglycemia, high levels of glucose in the circulation. It also causes acute conditions of ketoacidosis. Some of the secondary complications of type 1 diabetes include heart disease, blindness, and kidney failure. And the pathophysiology of type 1 diabetes is similar to type 2 diabetes, where you have a hypothalamic signal of adrenocorticosteroid hormone that would trigger the adrenal gland to produce cortisol or corticosteroids, which would release adipose tissue to glycerol and free fatty acid, because the system would think that with the low levels of insulin, the system would think that the person is starving, because the insulin is the one that controls the free fatty acid release or the lipolysis or the breakdown of lipid from the adipose tissue, and that results in increased levels of free fatty acid. And you would also have increased levels of glucagon, because insulin basically blocks the action of glucagon, and increased levels of glucagon would trigger the glycolysis process that would also result in glycerol to making gluconeogenesis, glycogen breakdown with increasing glucagon, which would lead to more glucose into the circulation, which actually feeds towards the damaging or feeds towards. There's also blood circulations of glucose is high. You also have glucagon that acting on these patients, thinking that there is undergoing, because there is less insulin, the system thinks that they are in the starvation time, and they produce more glucose from the liver, from the substrate that they could get, like glycerol from the adipose tissue, lipolysis. It also gives acetyl-CoA and ketone bodies, and excess amount of ketone bodies results in ketogenesis, and that's another problem with type 1 diabetes. What happens in insulin deficiency in type 2 diabetes is increased gluconeogenesis. The gluconeogenesis is a process that makes glucose from non-carbohydrate substrates, and we talked about lipolysis. That means breaking down lipids, and elevated levels of free fatty acid and utilization of free fatty acid results in generation of ketone bodies that could form diabetic ketoacidosis. And if someone has a diabetic ketoacidosis, that could also lead to coma and death and when they have a chronic hyperglycemia. And these hyperglycemia could also have macrovesicular and microvesicular diabetic complications, where they could affect the heart and results in cardiovascular disease. And they could also have renal disease, diabetic retinopathy. That means a block or neurons in the eyes are damaged, and retinopathy happens, and peripheral neuropathy is another damage even that happens with type 1 diabetes. And these are the severe symptoms. A very simple therapy for type 1 diabetes is insulin administration. I wanted to have introduce insulin resistance to this audience, and there's also a video that is listed here in YouTube. Please pause here and go to this exact link and take a look at the video, and that would explain what is insulin resistance. And this would be a great break for you, and to know what is insulin resistance. I will briefly explain you what insulin resistance is. If you have glucose, high levels of glucose after a fed condition, and our body senses, pancreas senses, and insulin gets made. And if your body or in this organ or the system maintains glucose level, that means insulin sensitivity. If so, that is depicted here. So if you ingest or if you intake of glucose is high, and your circulating levels of glucose should be maintained, that glucose it gets utilized in the liver as a glycogen, but you can only store that certain amount of glycogen in the liver. We have lots of muscle, and muscle would help in taking this glucose with the help of insulin. The insulin action result in uptake of glucose with the glucose transporters, and it also helps in uptake into the muscle cells. The insulin resistant means the circulating levels of glucose is high, and you are also ingested high levels of glucose or the carbohydrate diet, and insulin is also high. In spite of high levels of insulin, the absorption of glucose from the circulation to the muscle and the liver is not so good. That is called insulin resistant, and that happens in type 2 diabetes. So to give you more introduction or to explanation of insulin resistant, this happens when someone is hyperinsulinemia. That means you have high levels of insulin in the circulation, and despite having high levels of insulin, the body or the muscle and adipose tissue is not responding to the high levels, and that is called insulin resistant. And there would be a compensation or compromised insulin sensitivity that creates pancreas to secrete more insulin and to compensate the reduced insulin sensitivity. So in a sense that our pancreas would work along high levels of producing high levels of insulin so that some amount of glucose regulation can be made. And this compensatory mechanism later is destroyed or lost. That results in severe type 2 diabetes. So in the muscle, reduced levels of insulin would stimulate glucose uptake, and in adipose tissue, increased lipolysis and free fatty acid would happen if someone has insulin resistant. However, liver and kidney would retain the sensitivity, and in turn, because of high levels of insulin, they would be making more lipids, and they will take glucose, and that make if you have, because I told you that you can only store certain levels of glycogen in the liver, and after that reached the saturation point, they would be start making into lipids. They would be starting to make fatty acids, and that would go and accumulate in adipose tissue, and after the overnight fasting time point, these accumulated lipids would come back and damage pancreas and liver, and again worsens the disease. The insulin resistance is the key, and in response you have elevated levels of triglycerol, and we know that metabolic syndrome or type 2 diabetes is associated with non-alcoholic fatty liver disease and elevated levels of triglycerides and fat accumulation. There would also be renal sodium retention, and because and that renal sodium retention would cause hypertension or increased blood pressure and increased uric acid level. Altogether again causes inflammation and damage to the kidney. So with that, I would ask everyone a question: what is an insulin resistance from what we have learned so far? So this is something that I wanted to take it to the class, but I'm going to go through. Insulin resistance is something that muscle cells does not respond to insulin, and adipose tissue again does not respond to insulin. However, glucose at the same time, because of this response is blocked, glucose cannot be absorbed into the muscle and adipose tissue from the blood circulation, which results in hyperglycemia or high levels of glucose in the circulation. And to compensate that, beta cells would produce more and more insulin to maintain the blood glucose level. So the answer would be all the above. Now we have learned about insulin resistance, and I wanted you to go to type 2 diabetes as metabolic syndrome. What is type 2 diabetes? This is often referred as referred as non-insulin dependent type 2 diabetes or adult onset diabetes. We no longer call adult onset diabetes because we have seen adolescents of 10 to 13 develop type 2 diabetes because they are obese, and severely obese patients in the children's do develop type 2 diabetes, and that's why we don't no longer call adult onset diabetes. And they are characterized by high blood glucose level, and insulin resistance happen, and related insulin deficiency happens at the latest stage of the disease development. And again, type 2 diabetes is highly associated with obesity and metabolic syndrome, and they are intimately associated. There is insulin resistance, and distribution of body fat is enormously visceral adipose tissue. That means adipose tissue or high accumulation of adipose in the abdomen or visceral adipose tissue. But most obese and insulin resistant subjects do not develop hyperglycemia due to a beta cell compensation at certain age. But the beta cell compensation is lost, then that would result in type 2 diabetes. Until your compensation is doing a good job, you will not get a type 2 diabetes. But if there is insulin resistant obesity and there a beta cell dysfunction happens, that will result in type 2 diabetes. That's why this is a benign disease or a silent disease that you would not know until your beta cell dysfunction is happening. And when the beta cell dysfunction has happened, it's too late to turn around and go back. And that's why it's important to maintain a healthy weight, and development of type 2 diabetes can be blocked in the pre-diabetic stage. So here is a nice diagram to show how there would be a pathogenesis of a type 2 diabetes happens. So here what happens is, in a healthy individual would have good levels of pancreatic islet cells that would produce normal amount of insulin, and if someone gets overweight, there will be compensation of beta cells, and the normal islet levels would be proliferated, and that proliferation would compensate the levels of insulin in the circulation. But if it keeps on compensating in years and years of accumulation of injury, and there would be starting or tipping point of, due to the overnutrition, inactivity, and other environmental factors, there will be beta cell dysfunction, and beta cell destruction would cause type 2 diabetes. And here you would have a normal glucose tolerance test, and here you would have improper or impaired glucose tolerance test. But by this time point, you would be complete loss of beta cell failure. There will be a severe type 2 diabetes development, and that would be a problem. And if someone is morbidly obese or heavy obese people, that they could develop this. So this process doesn't happen in a day or two. It takes years and years of injury and accumulation. For example, a fasting blood glucose is about 70 to 100, and if someone gets insulin intolerance, it doesn't happen in a day or two. It depends. The pathogenesis of type 2 diabetes changes, and you would see that it varies from 10 to 30 years. And during the 10 to 30 years, until the beta cell compensation, they will be slowly increasing the blood glucose level in the fasting stage time point. And at the time point when you have more than 126, and you no longer and the fasting blood glucose goes down, insulin resistance continues to improve, and again that takes years and years of injury, and insulin resistance continues to grow up, and your beta cell compensation is normal levels of insulin production is here when you have a good levels of blood circulation. But in the increased levels of glucose insulin insulin would also be compensated to prevent the type 2 diabetes incidence. When the beta cell compensation is done, when beta cell dysfunction happens, and when there is no longer having increased levels of insulin production, your fasting blood glucose level goes up, and that would result in type 2 diabetes. And why we have to think about obesity and metabolic syndrome, because insulin is highly associated with elevated fasting blood glucose level, and elevated fasting blood glucose level, hypertension with low HDL cholesterol and high LDL cholesterol, along with elevated triglycerides and abdominal obesity, then this is called a metabolic syndrome. The definition of metabolic syndrome and the metabolic syndrome is vice versa, highly associated with type 2 diabetes, non-alcoholic fatty liver disease, and the non-alcoholic fatty liver disease could progress towards non-alcoholic steatohepatitis, liver cirrhosis, and later for hepatocellular carcinoma. And that's a progression of other part of the liver injury that happens because of metabolic syndrome. And obesity and metabolic syndrome are highly associated with non-alcoholic fatty liver disease and also with type 2 diabetes, because this injury mechanism is similar in both processes. Okay, so if someone calls if you one of the you don't have to have all five to call someone as metabolic syndrome. 3 of the 5 is enough for someone, like for example, but they are all highly associated with each other. So to be a metabolic syndrome individual, you have to have a elevated waist circumference, and you also have to have elevated levels of triglycerides, reduced HDL cholesterol, and I'm not going to go through the levels. You can pause and take a look at the levels, and elevated blood pressure and elevated fasting, and again that's metabolic syndrome. So this is key to maintain this, and very important point that I wanted to mention here is the exercise blocks, or weight loss due to exercise blocks the progression of metabolic syndrome or type 2 diabetes or non-alcoholic fatty liver disease. And the way that happens in why we would have to have a metabolic syndrome is related to elevated triglycerides, because we talked about before that high levels of insulin would block the circulating free fatty acids in the circulation, and if someone has deficiency in the insulin, then there would be high levels of circulating free fatty acid, which is damaging to the any individual. So in a normal individual, here's a 3 graph that goes. On the top one is glucose level, and on the bottom is the free fatty acid circulating concentration of free fatty acids. In a healthy individual, you would have high levels of free fatty acid in the circulation at 8 o'clock in the morning, and when you consume and the glucose would be high, but in the normal you would be below 100 milligrams per deciliter, and in pre-diabetic individual there would be a little bit higher. In a severely diabetic individual, the glucose levels will be around 3 in the fasting, 300 milligram per deciliter at the fasting stage. And with the meal or with the break fat, that's going to go up in all of the individuals, but in healthy it slightly goes up and comes back. And for a diabetic or severely diabetic, the increased level stays elevated, and you almost came back to the baseline where you started of below or 175, or in this case of severely diabetic individual, you have blood glucose levels of about 250 milligram per deciliter. On the other side, the people who are on severely diabetic, to start with, they have a high levels of free fatty acid in the circulation. With the meal, the free fatty acid goes down in the circulation, because you remember insulin blocks the free fatty acid in the circulation or the release of free fatty acid from the adipose tissue. And in the normal individual and pre-diabetic, they also lose, they come back, and again another in lunch you would have a decrease, and in the supper or in the dinner you would have a decreased levels of free fatty acid. But after the overnight fasting time point, again this free fatty acid levels goes up, because liver utilizes fatty acid while making glycogen, and the glycogen will be released during the overnight fasting time point, and liver would be compensating by utilizing free fatty acid for the energy production. So does heart and many other organs. And in a severely diabetic individual, their free fatty acid circulation is enormously high compared to a diabetic or pre-diabetic individuals. These high levels of free fatty acid in the circulation is not good because they could cause something called lipotoxicity to the pancreatic beta cells, and that causes pancreatic beta cell destruction or apoptosis. And these elevated levels of free fatty acid also causes liver cells or hepatocytes and cholangiocytes undergo lipoapoptosis and cell death. And that is the key mechanism behind free fatty acid induced lipotoxicity that happens in metabolic syndrome, obesity, and type 2 diabetes and non-alcoholic fatty liver disease. So to summarize, and the type 2 diabetes results in, and there are various genetic predisposition factors, and overnutrition and obesity lifestyle factors causes insulin resistance and beta cell compensation, and that would make someone to have a normal glycemia. And then at certain time point to 10 to 30 years of age, there would be a beta cell failure, which results in impaired glucose tolerance. And at the late stage of type 2 diabetes, that when you would have beta cell failure, complete destruction of beta cells or pancreatic beta cells because of high levels of free fatty acid and other environmental factors could cause type 2 diabetes. And that results in the generation of type 2 diabetes. And there are some of the treatment that is available is insulin insensitivity or weight loss. So and not all overweight people or obese people would develop insulin resistance, and some of them are insulin resistant or insensitivity, and not everybody develops type 2 diabetes. That changes again and due to the various predisposition factor. And the weight loss, like I mentioned before, is very, very helpful in improving the insulin sensitivity. And low fat, high carbohydrate diet is not good for someone who is type 2 diabetic, because you will have to have, whenever you consume high carbohydrate diet, then you will have to make insulin, and you have to utilize insulin to do the blood glucose, decrease the blood glucose level. So the maintaining diet is very critical. And metabolic syndrome, insulin resistance are active area of research in my lab, and I would probably talk about this in our future life science discussion forum. I can also talk about how we could mechanistically how these increased free fatty acid levels causes hepatocyte lipotoxicity. And I wanted to go back to the first slide, and then I wanted to thank the organizers of the Botany for You, and also my friend Nishikant Vasi for giving this opportunity to me to meet many of the students and across the globe. And see, here's my email. Feel free to reach out to me. I would be happy to answer any questions that you may have. Again, thank you so much for listening to this presentation via the Botany for You. Thank you. Bye.